So question 1 is saying a 44-year-old G1P0 with confirmed twin pregnancy at 31 weeks gestation is referred from a local clinic for further management of severe preeclampsia. List the symptoms of severe preeclampsia. Now we know that these hypertensive disorders in pregnancy is actually a spectrum starting with chronic hypertension going to the preeclampsia, which can be also divided into the mild and severe, isn't it? And then we have got the chronic hypertension superimposed on preeclampsia, and then we have got eclampsia, a spectrum really. So for the symptoms of severe preeclampsia, it includes persistent severe frontal headache. This headache is frontal. And then there'll be visual disturbances like blurred vision, flashing lights, scotoma. Scotoma is where you just show like one part of a visual field is blurred. And then epigastric or right upper quadrant pain. There's also oliguria, which is reduced urine. And then increase in vascular permeability that leads to generalized edema, pulmonary edema, and then cerebral edema. The cerebral edema will lead to these symptoms. So if you start having the seizures, then it no longer called preeclampsia, it will become eclampsia. So preeclampsia plus seizures, that's eclampsia. So those are the symptoms. So for the main symptoms, severe frontal headache, right upper quadrant pain, these visual disturbances. And then for the signs, you have got a BP which is greater than 160 over 110. Because remember the mild one, the BP is just going to be from 140 over 90 up to this 160 over 110. Greater than 160 over 110, that is severe. And then a proteinuria greater than 2 plus in 24 hours, that is 300 milligrams, that's the same 2 plus. And then facial edema, epigastric or right upper quadrant tenderness. So this one is tenderness because it's a sign. Okay, you are pressing there. And what causes the right upper quadrant tenderness? It's the involvement of the capsule, the liver. And then there'll be confusion. The reflexes are also going to be high, for example, hyperflexia or hyperreflexia. And then you have got clonus, which means that there is actually irritability to the cerebrum. The uterus can also be tender. Fetal growth can be restricted, but these ones will mean there's actually another problem. But the big ones when it comes to the sign is the BP greater than 160 over 110, proteinuria greater than 2 plus, and then you have got this right upper quadrant tenderness. Yeah, those are the big ones. And then B is saying by definition, what blood pressure reading will be classified as a severe preeclampsia. Now, we've already mentioned that on top, isn't it? So we define preeclampsia as a systolic greater than or equal to 160 and a diastolic greater than or equal to 110, measured at least twice 4 hours apart. So you can't say this is the hypertension when you have just measured once. We define hypertension as elevated blood pressure greater than 140 over 90 at least on 2 occasions repeated 4 hours apart. But since this is specific to severe preeclampsia, we just change the values to 160 over 110 to at least twice 4 hours apart. What level of proteinuria is considered significant for preeclampsia? Again, this one is already there. It is having greater than or equal to 300 milligrams per 24 hours or 2 plus. okay, on at least two random clean cut urine samples tested more than 4 hours apart in the absence of a urinary tract infection. Okay, so that proteinuria is going to be significant, 2 plus or 300 milligrams per 24 hours. What laboratory and imaging investigations are you going to order in this patient? So, for someone that has got preeclampsia, what labs and imaging can we do for these patients? Anyone who can help? Anyone? Yeah, basically that. As we can see, one of the signs when you do a fetal, when you look at the fetus, especially if the pregnancy is less than 36 weeks, you discover that there is going to be restriction of growth. There is fetal growth restriction when you do the ultrasound. So I want to check for that. So for the labs, you can do a full blood count. Okay. So for the full blood count, what are you going to be able to see? You'll be able to see a high hemoglobin, and this is because of hemo concentration. Like plasma will start leaving the blood vessels and go into the tissue, and that leaves uh, hemoconcentrated blood. And then there will be thrombocytopenia. There's going to be anemia sometimes if there is hemolysis. And then, but thrombocytopenia is important for us to take note of. For the we can also do coagulation profile where we look at, because this can actually pretend us to bleed. Okay, prolonged PT, APTT, increased bedtime clotting. Biochemistry, we can also do the in the liver function test, kidney function test. For example, the kidney function test, we can do the urea, the creatinine. The liver function test, AST, ALT. And then we can also look at LDH, which is a marker of hemolysis if it's elevated. And then you can also do the urinalysis. For imaging, we can do the obstetric ultrasound for evidence of intrauterine growth restriction, and the umbilical artery Doppler to evaluate if there is enough blood that is going to the child, because actually it's because of not enough blood going to the fetus which leads to intrauterine growth restriction. So when you do the Doppler ultrasound, it will actually show us. Okay. So he is saying, what is the drug of choice for seizure prophylaxis in this patient? So for the prophylaxis of seizures, we use magnesium sulfate. Specifically, there is this one, the formulation which they call the Pritchard, where you give 5 grams, 50% magnesium sulfate solution IM, and then 1 ml of 2% lignocaine every 4 hours in alternate buttock until 24 hours after birth, or at least or after the last conversion. Yeah. So I've seen some questions where they've given these doses. Please take note of the pre-chart. 5 grams, 50% magnesium sulfate, IM&D, 2% lignocaine every 4 hours in alternate buttocks. So you can, yeah, you can give this one for 4 hours until 24 hours, or after birth. Yeah, until 24 hours after birth, or after the last conversion. Yes, my good doc.
for this, there's a question. Okay, a working where there is this postcard test with this for the somebody can when it's look at the branch of government of IT from after 4 minutes or 4 minutes essentially minutes when they give 5 milligrams. Oh, I don't know if it's milligrams of magnesium sulfate from raw potatoes, which is 5 something.
Oh, okay. I'm not just sure of that one.
So
Hmm.
these are like all together. Okay? So all together, the dosage is equivalent to about 14 milligrams.
Okay. All right. Thank you so much. Hmm. So at least at this level, because we are not much going to go in details about the dosages, specifically because the pre-chart is the most common. So they actually mentioned we just have to be aware of this pre-chart formulation for the prophylaxis when they were when they were teaching this one, at least for this level. And then the details of the doses we keep them for the coming year. Yeah. So sometimes they can be overdose of the magnesium sulfate. So what can you do in that case? You can give the calcium channel. Actually, first the way magnesium sulfate itself works is it is going to work on the calcium channels by blocking the calcium channels, specifically the L type. It also has the neuromuscular effect. So when you work on the calcium channels, you are going to cause vasodilatation. And this vasodilatation will mean that the BP is going to be lowered. It also has the neuromuscular effect by decreasing acetylcholine release. And this will lead to muscle relaxation and reducing hyperreflex, which is present in preeclampsia. And then it can work also on the central nervous system, specifically on the NMDA receptors as an antagonist, and that will reduce the excitability that prevents the seizures. It can also work as a bronchodilator by relaxing the smooth muscles. So the use of magnesium sulfate has got side effects. So the common ones, which include flushing and warmth, nausea, drowsy, but this is not important. The ones we are more interested in are the serious side effects of toxicity or signs of toxicity of magnesium sulfate, which is the signs of hypermagnesemia. Signs of hypermagnesemia includes hyperreflexia and respiratory depression. Please take note. Okay, respiratory depression can lead to apnea if magnesium sulfate is so high, and then there can also be hypotension, bradycardia, and oligo, oligouria. Actually, the important ones, every time you are giving magnesium sulfate, you want to make sure that you are doing these CNS exams, specifically the deep reflexes. If there is hyperreflexia, it might mean there is toxicity. Another thing that you always want to follow is the respiratory system, taking the oxygen stats and also doing the respiratory rate, because there can actually be respiratory depression. You discover that the respiratory rate is less than 12 breaths per minute. Another thing that we do is we follow the urine output, okay, when you are giving magnesium sulfate, because there will be oliguria. You discover that it's going to be less than 0.5 milligrams per kg. That's per hour. Okay. So these three are important: oliguria, hyperreflexia, and respiratory depression. So if there is poisoning or toxicity of magnesium, you can give calcium gluconate, which is the antidote. Now, magnesium sulfate has got other therapeutic uses, like in the management of seizures, cardiac arrhythmias, and then asthma treatment as a bronchodilator, also for neuroprotection in the preterm, okay, in preterm labor. Also for electrolyte, if there's electrolyte replenishment, so to correct hypomagnesemia, and also for migraines and nephritis. So those are other effects of magnesium sulfate. Number two is saying an 18-year-old preemie gravida at 33 weeks gestation is seen in admission ward with a history of vaginal bleeding. What four questions are you going to ask her? Someone comes with vaginal bleeding at 33 weeks. What questions can we ask her?
So, so your breath understand the bleeding constantly,
Mm.
and how much blood have you lost? And is, is the bleeding associated with heavy pain? Um, and what color, as well as the pressure of blood?
Yeah, thank you so much. Those are some of the questions we can ask. Are there other questions that someone is thinking of that we can ask? Okay. So when did the bleeding start? That is going to help us to characterize if it's acute or chronic. What is the color and the amount? For bright red, that will mean it's actually a previa. And then for dark or the clotted blood, it can be an abruptio. If there's any associated pain or uterine contraction, so painful bleeding will mean an abruptio, because for a previa, usually painless. And then we'll ask about the history of recent trauma, okay, which can identify maybe there is a possible cervical pathology, or maybe for trauma there can be uh, abruptio placenta. Is the bleeding continuous or intermittent? And that will also help us to differentiate chronic from sudden onset, the chronic from the acute. Normally, for sudden onset, bleeding is going to be an abruptio, and then the gradual spotting will be a previa or cervical pathology. Abruptio is sudden. And then you also ask about fetal movements. Are they normal, decreased, or absent? Can indicate also maybe there is a intrauterine fetal demise. Any previous episode of bleeding during this pregnancy? Okay, maybe there's a placental pathology. And then also antenatal scan confirming the position of the placenta. It can help if probably the mother knows of the previa or abrupt, actually specifically previa. Yeah. Any recent vaginal exam or sexual activity, because it can literally be maybe after sexual activity there was the irritation to the cervix. Okay. And any history of hypertension or preeclampsia, because it can actually increase the risk of an abruption. The next B is saying list four differentials. Someone that comes with vaginal bleeding, what would be the differentials we can give? Already from what you've said here, we can pick the differentials. Anyone?
good. And because there is placenta previa, placenta ejecta, placenta, vasa previa.
Yeah. So we can have those placental problems like placental previa, placenta abruptio, and vasa previa. Anything that can cause bleeding from the vagina. Cervical pathologies, right? They can also be the cause. So cervical pathology, uterine rupture, especially if there was surgery or trauma. And then preterm labor, coagulopathies, for example, the HELP syndrome or disseminated intravascular coagulopathy. And then the trauma to the genitals, like a vaginal laceration, maybe the patient was raped. For the HELP syndrome, this is very important when we're talking about preeclampsia. What does HELP stand for? The H, the E, the L, and P. Anyone?
Okay. Okay. What medicine? L has elevated liver enzyme. Help is helpless.
Okay. Thank you so much. So we know when you're talking about preeclampsia, one feature is there can be hemolysis, there can be elevated liver enzymes, the AST, ALT, and then the platelets can be low. That's thrombocytopenia. That gives us the HELP syndrome. C is saying, what would you look for on examination of this patient with all these differentials that you've given? When we are doing the exam, what are we going to be looking for? Okay, so depending with the differentials that we are thinking of, for example, if we are trying to compare previa and abruptio placenta, in the exam, when you look at the bleeding, okay, for the clinical features, the bleeding for previa is normally painless, and then it is causeless and recurrent. Okay, like you don't know the cause, it just happens. And then the bleeding is always reviewed. In other words, when someone is bleeding, what is coming out is going to be coming out. Okay, it's reviewed. But in abruptio placenta, the bleeding is painful, and normally there might be history of trauma there other than previous where is causeless. And then the bleeding can either be concealed or revealed, meaning that someone might be bleeding, but then the blood is not coming out from the genitals. Instead, it's just remaining inside. For the character of the blood in previa is going to be bright red, in abruptio is going to be dark red or dark colored. And then for the general condition and anemia in previa is going to be proportionate to visible blood loss. So someone has got anemia proportionate to the blood loss. For abruptio is going to be out of proportion to the visible blood loss, because remember the loss is actually less than what is really lost, because there is the blood is concealed. The features of preeclampsia might not be there in previa, but they are present in like a third of patients in of abruptio. And we know the features of preeclampsia when you are doing the exam, right? Like the tenderness, okay. And then when you do now the abdominal exam, this is the important one for the examination. The height of the uterus is going to be proportionate to the gestational age in placenta previa. In abruptio, it's going to be enlarged in the concealed type. Okay, like it's bigger than normal. For the feel of the uterus, in previa is going to be soft and relaxed. In abruptio is going to be more tense and it's painful, it's tender and it's rigid. For the presentation, malpresentation is going to be common in previa. The head normally, like when you are feeling for the head, is going to be floating. It's way on top. That's because down where the head is supposed to be engaged down, there is actually the placenta there, so the head can't be down. Okay, so the head is way up. While for abruptio, it's really unrelated. The head may be engaged. Okay, and then for the for the height, okay, this FHS, I've forgotten the meaning. And then for the vaginal exam, if anyone knows the abbreviation, they can tell me. Vaginal exam, the placenta is going to be felt on the lower segment, like the bottom. Sorry, someone was saying something. Okay, all right. So the placenta is going to be felt down, and then that is for previa. But in abruptio, the placenta is not felt on the lower segment. And yeah, yeah, this is the fetal heart sound, the FHS. For previa, the fetal heart sound is usually present, and then for abruptio, it might be absent, especially in the type where it is concealed. Okay, so those are the features, especially the features on the abdomen, like the height of fundus, the feel of the uterus, the presentation, and also the heart sound. List four investigations you'd carry out to help you arrive at your diagnosis. So again, now for this one, what would you look for on the exam? We are comparing these two because they are the biggest cause of bleeding, vaginal bleeding, but you can also think of others. For the investigations, the labs, the full blood count, where you look at the HB, the platelets, and also, of course, blood grouping. For the HB specifically, want to look at anemia, the platelets, coagulopathies, they can have bleeding tendencies. Okay, maybe that's why someone is bleeding. They just have a bleeding tendency because of low platelets. And then we can also do a coagulation profile to rule out TDIC and HELP syndrome. Urinalysis also to look for the proteins. Okay, maybe there's kidney injury. And then imaging, the ultrasound to look at the position of the fetus. Okay, and also to look at the location of the placenta. Where is it really? Is it down for previa or not? And then, is the fetus growing for the ultrasound? Maybe there is intrauterine fetal demise. And also to look at the levels of fluid. Okay, so those are the labs and imaging that we can do. You can also do a clinical exam by doing a Cusco exam or the speculum exam, so that you exclude local cervical and vaginal lesions that might cause bleeding. Yeah. Now, vaginal exam must not be done really. Okay. The problem is that when you are doing this speculum exam, this is an exam that you're supposed to avoid, this digital vaginal exam. Instead, you should just do an inspection to see whether bleeding is present or absent. So in vaginal bleeding, you want to avoid the digital vaginal exam, because if it was in placenta previa, you can actually worsen the bleeding. So what exam are you going to avoid? Is the digital vaginal exam. So you just do inspection instead of doing the exam itself. So that is it for that question. So we go to question 2, to question 3. Hope that's okay. Is there any question or any other addition before we go to the next one? All right. So the next one is saying study the picture below and answer the questions that follow. Name the procedure being performed. Anyone? What is this procedure we can see here? Okay.
vacuum delivery.
Yeah, this is a vacuum assisted delivery or vacuum extraction, also known as a ventouse or ventouse delivery. List one fetal and two maternal indications for this procedure. Why should we do a ventouse? What are the indications?
Implication of advantage for below labor. So, prolonged labor.
Okay. So, yeah, for the indications, we divide them into fetal indications and the maternal. For the fetal, we can have things like a non-reassuring heart rate. That might mean maybe there is a fetal distress. What can we see in that case? Bradycardia or maybe late decelerations. Yeah. And then malposition of the fetal head, where you have got the occipit, posterior, or transverse position. Like for example, you can see here, this is actually occipit anterior. But if there's a malposition of the head like occipit posterior or the transverse position, another indication. If there is need to shorten the second stage of labor because of fetal compromise, for example, you're suspecting fetal hypoxia, you want to shorten the second stage of labor, you can as well do a ventouse. If there is a prolapse of the umbilical cord or premature separation of placenta, this one can also be an indication. Because if the placenta is separated, it means that there will be no nutrition, no oxygen coming to the fetus. You don't want the fetus to die there, so deliver them. And also prolapse is a bad problem. So fetal distress also, for example, what are some things that you can look at? Reduced fetal movement, meconium staining of amniotic fluid, the changes in fetal heart rate. For the maternal indications, things like maternal exhaustion or distress, so where the mother is not able to push due to fatigue or a medical condition, or prolonged second stage of labor where it can't progress even when there are contractions that are happening. Also, cardiac or respiratory diseases and neurological diseases like myasthenia gravis, where the maternal effort is going to be limited. Those can be indications for ventouse. C saying list 8 prerequisites that must be met before this procedure can be done. Anyone that wants to help with that? So, before you can do a ventouse, number one, you want to make sure that the cervix is fully dilated. You can't do ventouse if the cervix is not fully dilated up to 10 centimeters, so that they can be self passage of the fetus, right? Number two, the membrane should have ruptured, right? In case they've not ruptured, you can rupture them, manual rupture. And then the head should be engaged. So the baby's head must be low. Okay, it should be engaged. And then the mother should have also some at least adequate effort, so that as you are pulling with the ventouse, the mother can also push. So adequate maternal effort. And then there should be no cephalopelvic disproportion, right? So the baby's head must fit through the pelvis. If there is this cephalopelvic disproportion, you might not be able to to go through with this procedure. And then there should be defined fetal position. So the baby's head should be determined, and the one that you prefer is the occiput until you're able to deliver, or the vertex presentation. And then the experience, you need also an experienced operator, because these features can be there, but if the operator cannot be able to perform the procedure, it can be really challenging. And then the mother should have given consent. And of course, as you are doing this, the bladder is emptied. So 1, 2, 3, 4, 5, 6, 7, 8, and an extra of the bladder being emptied. List two maternal and two fetal complications of this procedure. The first thing first that you should think of is a cephalohematoma. So for the fetal complication cephalohematoma, they can also just be an injury to the scalp, or they can be an hematoma on below the aponeurosis of Galen, or subgaleal hematoma. They can also be intracranial hemorrhage, neonatal jaundice, okay. Then they can as well be subconjunctival hemorrhage. For the maternal complications, it includes perineal, vaginal, labial, periurethral injuries, and also just cervical injuries. They can as well be the annular detachment of the cervix when applied with incompletely dilated cervix. Imagine the cervix gets to detach from the uterus. They can as well be traumatic postpartum hemorrhage. After you've done this procedure, someone just starts bleeding and bleeding and bleeding. Other fetal complications include retinal hemorrhage, because remember the eye, cranial nerve that goes to the eye, optic nerve, is part of the central nervous system. So when there is this bleeding in the central nervous system in the brain, it can as well go to the retina. It can as well be fetal death, right? Fetal death asphyxia because of difficult vacuum extraction. So sometimes you also have contraindications to doing this procedure, and the contraindications includes, for example, basically what we talked about as a prerequisites, and you turn them around. The operator's inexperience, the inability to assess the fetal position, because there are specific positions that you want. For example, if there is a CPD, cephalopelvic disproportion, you don't want to do it, right? So the suspicion of cephalopelvic disproportion, fetal coagulopathy can actually lead to bleeding. Preterm babies who are less than 34 weeks due to the risk of fetal intraventricular hemorrhage. And then for macrosomia, if the baby is too big and you are trying to pull, it might not be able to work. Soft tissue obstruction in the pelvis, and also breech presentation and the face presentation. So these ones also you want to avoid doing eventios. Right. Is there any addition on, or any question on it? Question 3. Okay. Question 4 is saying a 32-year-old nulliparous woman presents to the gynecology clinic with abnormal uterine bleeding, AUB. List 8 causes of abnormal uterine bleeding. Anyone who can help us with any? For for the abnormal uterine bleeding, we have got conditions like a polyps, adenomyosis, which adenomyosis and endometriosis nearly the same condition, except for adenomyosis you have endometrial tissue growing somewhere else. If the endometrial tissue is growing in the myometrium, that is going to be the endometriosis, but in any other region that would be adenomyosis. You can also have the leiomyomas or the fibroids. These things actually have got a mnemonic. Anyone who knows the mnemonic. And then you have got the polycystic ovarian syndrome. Can also cause abnormal uterine bleeding, endometrial cervical cancer, coagulopathies, ovulatory dysfunction, and also iatrogenic causes, the causes that uh, come from, for example, hormonal therapy or drugs that you are taking, and coagulants. Those can all result in this bleeding. Endometrial hyperplasia, where there is thickening of the uterine lining, which can be precancerous, can as well lead to this bleeding. And then infections like endometritis and cervicitis can cause also the bleeding. Okay. Anyone who knows the mnemonic to use when you're remembering the causes of abnormal uterine bleeding?
The pneumonia is priming, and for the priming, is structure positive AUG, and the priming non-structured.
Okay, so the palm coin. Okay, like that. Then the N at the end, where the P is the polyps, adenomyosis, leiomyomas or the fibroids, and then these will be malignancies, coagulopathies, and then you have got ovulatory dysfunction, iatrogenic, this one, endometrial or cervical cancer. So the M should be another one. Since the
Malignancy,
if we say E is the endometrial cancer, and then N,
non-specific,
sorry,
non-specific,
oh yeah, the N is non-specific, and then the M is representing what?
malignancy.
The malignance, and then the E.
And not sure, I forgotten.
Okay, so the M, if we say M is for the malignancies, that would be now the endometrial cervical cancer. We can say E is the endometrial hyperplasia, unless otherwise. So this is the mnemonic we can use. Okay, and then B is saying, what questions are you going to ask her, which will help you determine the type of AUB that she has? So what questions can we ask to help us determine the type of uterine, abnormal uterine bleeding that this patient has? Anyone? Okay, so for the questions again, they're really a lot. For example, we can ask about the onset and duration of bleeding to help to differentiate if the bleeding is acute or chronic. And then we can ask about the pattern of bleeding. Okay, is the bleeding heavy, prolonged, intermittent, or it happens after sex? And then what is the color and consistency of the blood? Is it bright red or it is dark or clotted blood? To differentiate endometrial from cervical conditions. And then is there a presence of pain? Is there a pain? So this one can, if they are painful, it may mean adenomyosis or endometriosis. If it's painless, it might maybe be a polyps or hormonal causes. And then you ask about the regularity. Is the menstrual cycle regular? If it's irregular, can mean an ovulatory dysfunction. If it is regular, just heavy bleeding. And then history of gynecological conditions, for example, fibroids, polycystic ovarian syndrome, endometriosis, and then also the use of hormonal contraceptives or anticoagulants. Yeah. Other questions includes if the patient has noticed any recent weight loss, stress or excessive exercise, because this can actually lead to disturbance in the menstrual cycle, family history of bleeding disorders or gynecological cancers, for example, von Willebrand disease or endometrial cancer. And then we can as well find out about the B symptoms, for example, fatigue, and other symptoms like dizziness or palpitations, which might mean this patient has anemia. But this anemia will not tell us about the cause. Specifically, we want to ask questions that will help us identify the cause. What physical signs are you going to look for in your examination of this patient? So in the examination, if we look, because they are bleeding, we look for pallor. Abdominal tenderness may indicate things like, for example, adenomyosis and fibroids. We can palpate for pelvic mass, for example, ovarian mass or fibroids, and then enlarged uterus, for example, in fibroids and adenomyosis. Speculum exam might show us if there are any polyps, lesions, or infections. And then by manual exam, where we palpate the uterus for tenderness, signs of hirsutism or acne. So for hirsutism, there are menstrual irregularities, there is facial hair, and then you have got biochemical findings consistent with PCOS. Okay, so has to make a diagnosis of PCOS. And then bruising or petechiae might mean a bleeding disorder. And then for obesity, it's a risk factor for endometrial hyperplasia and also the polycystic ovarian syndrome. Signs of thyroid dysfunction, for example, a goiter. Okay, we know that if there's thyroid dysfunction, there's also going to be an imbalance in menstruation. List the investigations which you are going to do for this patient. So again, for the investigations, we divide them into labs and imaging. Labs, for example, coagulation studies to look at bleeding disorders, for example, von Willebrand disease. Hormonal profile like thyroid function, for example, follicle-stimulating hormone, luteinizing hormone, estradiol, progesterone, prolactin, and then endometrial biopsy to rule out the hyperplasia or malignance of the endometrium. For the imaging, we can do a pelvic ultrasound to assess the structure of the uterus, the endometrial thickness, and presence of fibroids or polyps. So that is on question D. Hope that's okay. Is there any addition? Okay. Number 5 is saying a 35-year-old G6P5 at 14 weeks presents to the emergency gynecology ward with a 2-day history of lower abdominal pain and vaginal bleeding with clots. She tells you that she expelled a fetus a few hours earlier. Upon examination, the cervix was found to be open and retained products of conception felt in the cervical os. Define abortion. Anyone who can help us to define abortion? Okay. So, abortion is the termination or expulsion of fetus before the age of viability. According to the WHO, that is below 24 weeks. In Zambia, it's below 28 weeks. Or we can say the expulsion of a fetus who is less than 500 grams. Okay, we know abortion can either be spontaneous or induced. It can happen by itself. In that case, it's a miscarriage. The induced can either be medical, the legal, or the non-legal. So in this case, what is our diagnosis? From what we can see, there is abdominal pain, vaginal bleeding with clots. And then she says she had expelled the fetus few hours ago. Okay. The cervix is open, and then there is retained products of conception. So do we think this abortion is complete? So this is actually an incomplete abortion. So what investigations are you going to do to help you confirm the diagnosis? For abortion, an ultrasound is very important to assess the retained products of conception and also to confirm if the uterus is empty or not. Okay. We can also do full blood count, coagulation studies. What is the name of the procedure that she will undergo to have her uterus evacuated? So in an abortion, there's a procedure that you want to do an evacuation so that whatsoever is there is out. But we don't do evacuation for every type of abortion. So the uterine evacuation, we perform it using an MVA, the manual vacuum aspirate, okay, which is preferred. In which age? That's less than 12 weeks. For dilatation and curettage, since the surgical removal of the retained products, that one will be after. The preferred one less than 12 weeks is the MVA. Okay. If you're saying what are the three components of post-abortal care? After an abortion, what are the three components of the care that is done? So what is done is there is the emergency treatment. After an abortion, you treat the complications like hemorrhage, infections, and the retained products. Because remember, these retained products can actually cause a lot of bleeding, right? And then you have got counseling and emotional support because this patient has just lost their child, so you want to counsel them and also give them contraceptives and family planning so that they don't end up having another child within this short period of time before even healing properly. Okay, so these three principles are important: emergency treatment of complications, counseling and emotional support, and then also contraception and family planning. Okay, the last question here for now. Mrs. Kakusa, a 49-year-old Paraten non-HIV positive woman, presents to gynecology clinic with complaints of postcoital bleeding and foul-smelling vaginal discharge. On speculum exam, she is found to have fungating mass arising from the cervix, extending to the posterior vaginal wall, causing a rectovaginal fistula. What is the most likely diagnosis? Any thought on this one? What would be the diagnosis?
The cervical cancer.
Okay, likely cervical cancer. Yeah, so cervical cancer. The next question is list 6 risk factors for this condition. What are the risk factors for cervical cancer?
One of them could be a multiple sexual partners,
Yeah, multiple sexual partners,
okay,
starting early to have intercourse, isn't it? Early age of intercourse because by that time the ectocervix is in the vagina. So that's where the transition zone is, where the HPV can go and stay. Okay. So persistent HBV infection, HIV infection because it causes immunosuppression, multiple sexual partners, early onset of sexual activity, smoking, lack of regular cervical cancer screening, and this is this is very important. Screening, long-term use of oral contraceptives, high number of pregnancies, like someone that is multiparous. This is opposite to breast cancer because multiparity is protective. And then family history of cervical cancer, and including also other cancers like breast cancer because, for example, you have got the BRCA, the BRCA gene 1 and 2 is associated with cervical cancer, ovarian cancer, and breast cancer. Also, poor nutrition, especially deficiency in A, C, and folate, can increase the likelihood of developing cervical cancer. What is the clinical stage of this disease in this patient? Now, from what you've been told here, we actually use the figure classification. The tumor has extended beyond the cervix to involve the posterior vaginal wall, right? And also the rectum, that is resulting in the rectovaginal fistula. So this is going to be the stage 3B. I'm just going to put the staging of the cervical cancer here so that we just see which stage falls where when you involve which part of the cervix or which part of the vagina, how much should you extend into which region for you to classify it even much further. How will you confirm the diagnosis? For cervical cancer, confirming the diagnosis, because it's a cancer, biopsy is always important for cancers to do the histopathology. Okay, that's very important. A biopsy. You can do imaging. Imaging will just help you in looking at metastasis, but to confirm diagnosis, biopsy. Mention two methods that can be used to screen for this disease. Screening for cervical cancer is very vital for, and what we use is the pap smear and the DNA HPV DNA testing. And then what are the prevention strategies for this disease? Well, prevent what causes it. For example, vaccination, regular screening. And this is very important. These two are very important for the screening and vaccination. Okay, should be done for everyone. Now, the vaccination is normally done in the sexually active, young, not really the sexually active, before they become sexually active, like at 11 years. Yeah, that's when you want to start vaccinating them. For screening, ladies are advised just to screen. Even us here, we are advised to be screening time at least in a while.